TopMedTalk.
Well, hello and welcome to TopMedTalk. We are coming to you live from the Society of Cardiovascular Anesthesiologists annual meeting of 2022. I'm Desiree Chappell, your host and co-editor-in-chief of TopMedTalk, and I'm joined by the other co-editor-in-chief of TopMedTalk, Monty Mythen. Hello, Monty.
Hey, Desiree. Desiree, great to be back on the road, as we say. Back in a live event.
It is. Can you believe it?
It's been a long while. We were at the ASA, but that was a predominantly virtual event. So we were there in the trade exhibition. We were celebrating the fact that we got to talk to people. But this is a full-on event.
Yeah.
This is although there is a virtual component to it, there are people here exchanging ideas.
That's right, and they definitely are. We've seen some fantastic lectures and different opportunities for all the attendees, which has been great just to see that for sure. Monty, the last time I think we had a meeting was in 2020, early 2020, January 2020. We were at SCA, though, back in 2019, weren't we?
Yeah. The Society of Cardiovascular Anesthesiologists, I'm sorry for those people listening to these podcasts back to back, but if you've just popped in, is one of the longest established gathering of practitioners in this space. So those people who look after patients having predominantly surgery on mainly the heart and the lungs. So that's right. A very executive summary there. And they've been gathering here for, I think, over 40 years, not necessarily this location. That's because it rotates around different places. So, and the current president is our friend Andy Shaw, Professor Andy Shaw. Yeah,
hopefully we'll be talking to him later. And thank you to the SCA for supporting TopMedTalk through the exhibit hall this year, which is great. We were able to do our little pop-up studio, which has been a lot of fun so far.
It is. And I've just come back from a great sponsored lunchtime session. So Edwards Life Sciences, who, as I think everyone knows now, is one of our generous sponsors, along with a longer list you can find on our website, sponsored a lunchtime session to discuss hemodynamic monitoring and management in patients undergoing cardiac surgery. Yeah,
Monty, we haven't really had a conversation about that in a while, so I'm really looking forward to kind of hearing the breakdown of what you guys talked about. But we want to introduce our next guests for you guys to kind of do a recap. So Brad Cardonell, who's a friend of the TopMedTalk family, for sure. But this is the first time we've ever been able to meet in person, isn't it, Brad?
That's right. Yeah, the last talk we had was Zoom. So it's finally nice to meet you and see Monty again and talk live here today.
Yeah, be in person. Well, thank you so much for joining us. Brad, you're the Director of Cardiac Anesthesia at the University of Missouri, among other titles. So tell us a little bit about yourself for those that may not have listened to your last podcast.
Well, the last podcast is there, so go listen to that one first.
That's right.
This will be the second one. So, I've been at the University of Missouri now for about 3.5, 4 years. I've had the fortune of taking over the director for cardiac anesthesia. And then also I serve as the anesthesia medical director for our university hospital, the main hospital there. So we're level 1 trauma center, stroke center, and with a smaller cardiac surgery program, looking to build that up over the next couple years with the heavy recruitment in both cardiac surgery and cardiac anesthesia. So.
That's great. Missouri, middle of the country.
That's right, yeah. We're straight in the middle between Kansas City and St. Louis. We serve all those patients in mid-Missouri that need surgery or care.
And you're recruiting, you said, right?
We are, yeah. We're recruiting heavily. So
who isn't these days?
So I heard it's one of the greatest places to work in the United States of America, not the world. Or that's what you were telling me as we walked over.
Absolutely. There are no downsides to the job.
It's perfect in every single way.
Absolutely, yeah. Great work-life balance, great money. What else are you looking for in a job?
Just satisfaction, job satisfaction.
Surgeons are great.
Yeah,
that's perfect. Yeah.
Oh, wow. Impressive. Well, I'm looking too, maybe.
Yeah.
I don't know.
We'd love to have you.
Yeah. Well, what I was just going to say is that sometimes when you think of the middle of the country, and I know I'm from Louisville, Kentucky, and this is what they always said, like technology and new practice kind of takes a while to make its way in from the coasts. But it sounds like you've been an early adopter of technology and new practices.
Yeah, I guess relatively so. I don't want to say that I'm the first adopter, a really early adopter, but because I was resistant at first. I think like a lot of people were. And if I think back to even some of the other technologies like cerebral oximetry, I was very resistant to that at first as well. When it comes to that, I saw a number, didn't see anything that I could intervene on, so I didn't see a utility in monitoring it. Now that practice has changed with the implementation of all the hemodynamic monitors and how I can use that in these high-risk patients to alter that perfusion and alter that cerebral oximetry. And same thing with the Edwards Acumen HPI. when it first came out and they first introduced it into our non-cardiac surgeries, I didn't think it was going to work, right? How is something going to tell us that the patient's hypotensive 10, 5, maybe 15 minutes before they become hypotensive? And I think it, just like everything, you can read the papers, you can read watch the videos, but until you actually use it and see it work in your own patients, it's not real.
So in the lunchtime session today, Brad, we had a representation from the UK, if I could claim that I was representing them, from Germany, and from Canada. And there were some very, very common themes that we went through there, culminating in our discussion, which we'll come back to in a moment, of the new technology, HPI, the Hypertension Prediction Index. And if I summarise from my perspective, it was silo budgeting, major complications are still there, acute kidney injury is probably avoidable, but the very common theme was also the staffing challenges. Are you seeing staffing? I know you just said you're recruiting.
We're recruiting.
But nursing in particular in the intensive care unit.
Besides that, I mean, it's still a great place to work. But yes, we're running into staffing shortages, and as I talk to my colleagues across the nation and the world, as you just mentioned, it's the same thing, right? I think I don't want to say back in your day, but back in that day,
back in our earlier days,
in the earlier days, you would drop a cardiac surgery patient off to a CICU nurse that had been there for 20 years, right? And you felt very comfortable and confident that patient was going to be well taken care of to the best of their ability and the best of the information that they had. Now, when I drop a cardiac surgery patient off, it could be to a traveler that may have cardiac experience. It could be to a CICU nurse that's just graduated and is being oriented to nursing as their first job. It could be to somebody that maybe have had 10 years experience, but I would say the majority of them are much less than the 5 to 10 years experience of cardiac ICU experience.
So we all spoke, and I think there was general agreement about the continuum of care that we aspire to. The fact that we targeted our monitoring to the patient's needs. So there was a sort of base monitoring that is for an institution, and then moving up through all the bells and whistles. But the real challenge we got into discussing was protocolization versus individualization, and how that mixes in with the transition into the intensive care unit with the variability you've discussed.
Yeah.
And you gave us 2 reflections there, Brad, if you could repackage them for us. Your attitude to what's going on in the OR, and then the challenges in the intensive care unit.
Yeah, so we were talking about goal-directed fluid therapy and using the advanced monitors in the OR, and the question was posed, do we have protocols in place for these patients? And kind of what we talked about, what I talked about is that I think it's going to be very hard to get a protocolized approach in the OR because it's a very dynamic environment. I also think that as cardiac anesthesiologists or anesthesiologists and cardiac surgeons, we tend to be a little bit more arrogant to say that we don't need protocols in place, right? So that we have all the technology there with looking at the right heart, the TE, the advanced monitors. And so it'd be very hard to follow a full protocol. I think we have the information there that we know we need to fill the heart with preload, and we have the parameters to be based off of that. And then we go to contractility and afterload. And I think we know to do that. I think when we go to the ICU, we need to give a standardized protocol, a little bit of approach, because the intensivist, the cardiac surgeon, the anesthetist, the anesthesiologist, whoever it is that's supervising the care in that unit is not at the bedside 24 hours a day, right? But the bedside nurse is. And we need to get that information to them and give them at least a similar set of objective data that we have in the OR to the nurses that are caring for the patients. And I think we can do that through some of these advanced hemodynamic monitors. We can still provide individualized care even with those protocols. So the individualized care can come in when Monty comes by, does a transthoracic echo, sees that the heart is contractility is measuring, well on the echo, look at the DPDT, it's 500-600 on the monitor, and know that that's our goal for the day. Or that, maybe we are on high-dose vasopressors and the SVR is running 1,300, but our goal is to kind of titrate those vasopressors off today. So we're going to change the goal to 1,000 for the patient for that day. And so it gives the clinician, the clinician the ability to individualize the care, but it also gives the nurse the objective data and the empowerment also to help make those decisions based off objective data. And these are dynamic patients, so they don't always follow an algorithm, and we all understand that. Yeah, they forgot to read the book.
Yeah, the text.
But if they follow the algorithm, or if the patient doesn't follow the algorithm, it also gives them the ability and the empower to say, I need the physician, the clinician at the bedside to evaluate this patient because we're not in the algorithm we should be in, and there may be something else going on with the patient.
Yeah.
And you find that people adapt to the algorithm quite quickly? Because the physiology is the same. It's preload, afterload, contractility. But you're sometimes throwing some new numbers at them, like the DPDT and the EA-dyne and those things. I think everyone gets cardiac output, cardiac index, stroke volume, heart rate.
Right.
Do they adapt fairly quickly? Because it all looks a bit complicated.
The alphabet soup.
Yeah, I think it can be, right? And you're also almost getting at a culture change with it as well, which is not easy anywhere, whether it's in the OR, before the OR, after the OR, in the ICU. So I think what helped us and what can help everybody implement this is let the people that are using it, the bedside users, develop the protocol themselves, right? It doesn't matter kind of what protocol you use at first. If you have something that's standardized, that makes physiological sense, then you can use that for a while, right? Know where the problems may lie or where it needs change, and then change it. So we're probably on our fourth rendition of the ICU protocol. And what we found is we kind of simplified it more and more each time to help with that. But it still isn't just putting something up there, having the monitor tell you information, and then it's fixed, right? Yeah. So you have to be able to interpret that information, know that it's actually quality information, right? This monitor isn't going to give you good information out if you put bad information in. So you need to know the basics to know that the arterial line is working properly, and that you're connected properly, and those type of things. So interpreting the information, knowing that it's reliable, and then intervening on the information as well, right? If we talk about HPR, the hypotensive predictive index, it can alarm all day, and it's not going to change the patient's outcome, right, if you don't intervene on it to prevent that hypotension.
And the key thing you said was if the algorithm isn't producing the results that we're looking for, that's the moment to call somebody back to the bedside for a discussion. Right.
And so we've seen that too. So we've had patients before the algorithm that were just flooded with fluids, right? Because the patient responded maybe briefly. I was maxed on vasopressors. I was maxed on ionotropes. I didn't know what else to do, was the comments I've heard before. So we've been able to provide the nurses with a couple fluid boluses to detect preload responsiveness, and then follow the algorithm past that. And again, if they don't follow it, then it's, hey, someone's got to come to the bedside and at least be notified. In these patients, it may be, I need mechanical support to treat this patient's hemodynamics.
Yeah. Well, no, I was just going to ask, speaking of algorithms, and I mean, I'm in the space of trying to develop whether or not it's called a protocol, a pathway, a guideline, like what is the language that doesn't turn everybody off?
Yeah,
it's not a
semantics.
Cookbook,
It's
not a cookbook. It's not, I mean, to me, and I've worked with, different types of technology and different algorithms and all these different things in numerous forms. And it's like we're actually individualizing when you're using this type of technology. One thing, though, that I have noticed, and you alluded to it, it's like keeping it simple is a big piece. Letting the end user kind of help make those decisions, them to understand. And I know there was in one of the Pokey papers from like 2018, the hemodynamic framework. It's like use your tools that you have, use these algorithms, but also use your brain.
Yeah.
And when it comes to nurses in the ICU right now, like how is that working? Because, some of the conversation for us is like, do we really want them to be able to, not that I personally don't want someone to use their brain, but like, do we want to give them that much freedom? Like, where are you guys in your protocol with that?
I mean, I think it's giving them guided freedom. So it's not that we've taken away the ability to give fluids, right? We're limiting that, and we want to see a result of giving the fluid. Yeah. So we don't want to see a liter bolus go in, and then we're not looking to see if anything changed other than blood pressure, right? So we're actually looking at the stroke volumes. So you gave a 250 bolus. Did the stroke volume go up 10%? Is the patient fluid responsive or not? You can do that 3 times. If it happens so on the third time that they're still fluid responsive, well, then we may need a clinician as well to look, do we have bleeding that's not detected? Do we have, do we need to check an H&H, an echo, those type of things? So it's giving them guided freedom to make those decisions in a protocolized manner. And then also on the same side, again, the clinician has the ability to individualize the protocol as well. So
for sure.
We have an SVR that is blank on our protocol. So what's your goal for that day for the SVR? What's your goal for cardiac index and DPDT? And again, it just helps guide the information that the nurse can titrate. And so we don't just base everything off of nurse experience or clinician experience, right? We
or just the number, or just a
pressure, right?
I mean, a lot of that's really empowering to me. That's how I feel like I've been able to get change and get people widespread adoption of things, is empowering the end user with the knowledge, the expertise, and the guidance and support, through all that. Yep. So sorry. Not to take over. What else did you guys talk about in your conversation today?
As you might anticipate, we had a great discussion about HPI, the Hypotension Prediction Index, which is increasingly the hemodynamic instability indicator as well.
Yeah.
And we were just reflecting as we walked over, it's still quite novel to a lot of people. It's been around for a few years, but we perhaps didn't lay enough groundwork there before we got into it.
Yeah, we got a question afterwards basically just saying, well, how does it predict hypotension if you're going to give the patient drugs that are going to cause hypotension? How does it work with that? And so I think one of the important things to know is that I kind of teach residents, I don't kind of teach, I do try to teach. I kind of teach them on a daily basis that, the HPI is basically a cardiovascular instability number. Mm-hmm. It's not necessarily saying that your preload is down, your afterload is down. It's much more dynamic than that. And the reason it uses machine learning is because we can't see those things on the bedside monitor. So we are relying on the artificial intelligence and the machine to kind of tell us those things now. So HPI is going to tell us that a patient's going to become, or higher likelihood the patient's going to become hypotensive. Now that's defined on the algorithm as a MAP less than 65, which is another thing that they were asking about. How do they define hypotension? And they were getting into, well, is it 10%, 20%? And so it's a straight number, right? It's a MAP less than 65, and the data is out there for that as well. And so it's not going to detect external factors. So in cardiac surgery, we have a lot of external factors that occur. If we start from the very beginning, it's induction of anesthesia, right? The machine or the algorithm is not going to know that you're going to push propofol and potentially decrease contractility, decrease afterload. So it's not necessarily going to detect that. But in some of these more unstable patients, and I had an example of it today, in a patient with a severe cardiomyopathy and aortic stenosis, even before we gave any sedative medications and hooked the patient up, the HPI was screaming 74, which basically just tells us objective information to know that the patient's hemodynamically unstable, right? Not surprising.
Right. I was going to say, no big surprise. Glad you got the confirmation, though.
Yeah, but it's objective data. And then what I was able to do is titrate my inotropes, titrate my vasopressors, and optimize that patient. So I got the HPI down to a number of 24 or so, and it was stable. Like before we optimized him, he was up, down, 74, 50s, and so I know the patient's unstable. So it's the whole idea that you can optimize that patient with the correct interventions to truly treat the etiology of the hypotension or the instability to optimize them before induction of anesthesia.
So it's really like a proactive approach more than the reactive of, their blood pressure's now low.
Because superficially, the normal numbers looked okay.
Right. Yeah, the MAP was, in the 70s the whole time. So, I mean, you bring the patient in the OR, MAP's 70s.
You're not going to treat that.
Right. Yeah.
I mean, unless they're severe hypotensive.
So there's I'm going to share an anecdote, level 1 anecdote now. Yeah. Because I heard it from another.
Grade A.
I heard it from another professor. It seems there's a possibility, like you were alluding to, that we're going to be able to predict the patient who crashes on induction, if you see what I mean. Now, we know there's a sort of phenotype of the patient who crashes, but there's also I didn't see that coming, in cardiac, which can get ugly sometimes. Which was a bit like what you showed us today. We don't know if they would have crashed or not, but you certainly got them so stabilized before you sent them off to sleep. That sounds cool to me.
Yeah, it sounds very cool.
Can't say it's definitely going to happen, but it's a level 1 anecdote.
we'll wait to see, I guess.
In case the FDA's listening, just say that's just a level 1 anecdote.
Can we quote that? Yes, that's great.
I like it.
I mean, honestly, I mean, how is that going to change the future of cardiac anesthesia if we have all that information?
Well, I think that's to be determined still.
Yeah.
I think it matters on how we use it and when we use it. We talked about the continuum of care quite a bit in the symposium as well. And, there are ways that we can monitor these patients prior to the OR, making sure that they're, fully rehabbed and optimized. Then we can go in the OR. That's where all the fun and games happens because we have every modality to monitor the patient.
Every toy.
But it's also the shortest time period of the patient's continuum, right? Hopefully it's the shortest time period. It's not a 12 hours in the OR, but, and then the patient goes to the ICU. And I think that's next area of focus. But it can't be lost either that the patient's going to go to the floor afterwards and go to rehab, or hopefully go home is the goal. I think Monty said it before, but a successful surgery is a patient sitting up, eating, walking the next day, and that's the biggest marker of it.
Yep.
It's not necessarily laboratory data or anything, but
drink, eat, move.
Yep, drink, eat, move. So I mean, that's the ultimate goal. Sounds pretty easy.
Living the dream.
That's right. So hypotension, we know that it's bad. We know it could potentially cause other things. We're still waiting on the whole connection thing. But you guys talked a little bit about AKI because that's one thing that one complication that we discuss a lot on TopMedTalk. How deep did you go on that?
Well, I mean, we only had 50 minutes in total to discuss everything that we got through, but we gave a good go of AKI, and I think the general acceptance was it's potentially avoidable, hospital acquired.
Right. Yeah, I think that was it was a global decision on that one from Germany, Canada, and the UK that there are certain interventions or proactive measures that we can take to prevent that AKI, and then it's going to be determined whether that affects the total patient's outcome or not.
That was a great point that was raised, is although we strongly believe that will follow through to long-term benefit, we always have to keep an eye on the fact that there might be some unintended consequences in what we do to avoid AKI. But the general feeling was feel very confident that it's going to turn out good, not good, bad.
Yeah. Well, you bring up a good point of like what we can cause when we're trying to prevent AKI. It's almost like let's take a step back of like what we're trying to prevent hypotension.
Yeah.
That's kind of brings to mind a little bit about are we making the right decisions? You think HPI and some of this has helped with that?
HPI has helped prevent the hypotension, right? But I think it's the secondary parameters and the objective information that provide you the true etiology of fixing that, right? It's so easy most of the time to fix a blood pressure with a number of, with a large amount of vasopressors. Yeah. It fixes it almost unanimously. Maybe
all your numbers, too, usually.
But that's not the goal, and that shouldn't be the goal. I think that was the goal before because that's all we had in the OR, right, was an arterial line and a blood pressure. Well, fix the blood pressure, the hemoglobin's normal, oxygen saturation's normal. We're doing our job. Patient wakes up. What more could you want? Your anesthesia team has completed grade A anesthesia. But we have to look further than that, right? Yeah. And it's going to take objective information. I think as anesthesia providers, we like that immediate gratification and we like that objective information. So do we have a way to know that the patient's contractility is down other than saying, well, his EF was 40% on an echo 2 years ago, so his heart's pretty bad, so he may need some ionotrope today. And that's kind of what I've saw in the OR prior to using this monitor is that it was always phenylephrine first, right? Because our drugs cause vasodilatation. And if phenylephrine failed, then you may think of levo, right? But then if levo fails, then you may think of the ionotrope. In reality, the ionotrope may have been the right call from the very beginning because all these patients, non-cardiac surgery, cardiac surgery, have sick hearts. They're older patients, and they're not optimized coming to the OR.
Yeah. Brad, I had a question. We didn't talk about this much before, but what kind of outcomes are you actually looking at your facility?
So we are in a dynamic environment right now with the number of cardiac surgeons we have and the cardiac surgeons that have come and gone. So we're kind of in a tough spot to say that an intervention like this is going to affect our outcomes when our cardiac surgeons change so much. Yeah, and it's also changing our patients that are coming to the OR. So once we get stabilized there, I think we'll have a better idea of how this can help.
Yeah, I mean, you're not alone. I mean, there is a data vacuum when it comes to especially outcomes. But it sounds like you guys made the decision to be able to utilize, advanced monitoring, new techniques, new, things that may cost be an investment or change in practice.
Yeah, we were kind of took the approach of let's kind of develop a cardiac ERAS program, knowing that we have some unstable personnel with cardiac surgery and nursing, as a way to say this is best practice, right? This isn't just developing an ERAS program, but we're going to make sure that we have best practices in place to try to help the other variabilities in our program.
Yeah. Good. Well, guys, it sounds like we kind of covered all the bases from the recap of the lunch symposium. Brad, thank you so much for taking the time to sit down. It was great to meet you in person.
Yes.
Finally.
Same. Yeah, thanks for having me.
Yeah, absolutely. Well, you're always invited back.
Appreciate
and come and talk to us anytime.
Well, just make sure it's excellent locations and I'll be there. Yeah.
I don't think we actually said in the beginning. This is in Palm Springs.
Yeah.
So, though it's absolutely beautiful, it is a bit warm.
That's what I hear. I haven't been outside yet today.
It's nicely air conditioned in here.
Lights are on. But if you look out the window, you can see some gorgeous views.
That is true.
Yeah.
Driving here this morning, we saw some gorgeous views. Anyway, thank you so much. Thank you to our sponsors. Thanks for everyone who helps us get to here and the different meetings that we go to. You can always find us at TopMedTalk.com. On our social media platforms, Twitter, LinkedIn, Facebook. We are there. All of this content's going to be on TopMedTalk.com, our app. It's going to be rolling out in the next day or so.
And the SCA, thank you for partnering with us. And I think if you want to still join in, you can join the meeting if you listen to this in time. And I think you can play catch-up too. And there's been some wonderful content there.
That's right. It's scahq.org. Thanks so much for listening. We'll catch you on the next one. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.